Hello everyone and welcome to our watch party on Across the Nations Treating Pressure Ulcers During the Pandemic, focusing on acute versus a community and how our processes differed. My name is Kirsty Marnie and I'm the Senior Tissue Viability Nurse for the Welsh Wounds Innovation Centre, and I will be your chair today. We'll be hearing presentations from Catherine Rowland, and she will be talking about mucosal pressure damage in the acute sector, and Lexi Dunmoon, who will be discussing her experiences in community with some very interesting case studies. We'll also be discussing how our different approaches in the three nations affect pressure ulcer prevention, looking at acute versus community. There will be an opportunity for you to discuss and ask questions during the presentation via our chat. I'm now going to hand over to Catherine Rowland, who will be giving her presentation on mucosal pressure damage. Thank you, Catherine.
Thank you very much, Kirsty, for that introduction. And hello, everyone, and welcome to my presentation looking at tissue viability from the acute setting during COVID. My name is Catherine Rowland. So this presentation, I'm going to introduce you to myself, go over a little bit of background about why I'm specifically looking at mucosal pressure ulcers in this presentation. And with that, there'll be a little bit of an overcap of pressure ulcer grading in general. Then we'll look more at mucosal pressure ulcers, and then we'll look at the device-related pressure ulcers because there's a lot of crossover between mucosal and device-related. And then we'll have a little bit of a look at what the wound treatment aims are around treating mucosal pressure ulcers. So about myself, my name is Catherine Rowland. I am a tissue viability nurse specialist and I'm based in Scotland. I've been working for 4 years now as a dynamic tissue viability nurse, which means I cover the acute and the community, which I love doing. I love that I get the insight into both areas because, as you'll see throughout this watch party, there really are quite a lot of differences between what's done in the acute and the community. So I'm very lucky that I can work in both. Previously to that, I was an ITU and critical care nurse for 10 years, and that is probably why I feel so passionately about mucosal pressure ulcers. It's something that we used to see infrequently, and it's definitely something that we've seen more of now with COVID, and like I said, we'll chat about that. So what is the background? The first thing is with pressure ulcers, the National Stop Pressure Programme aims to improve the consistency in the defining and measuring process of pressure ulcers, because we know that there are disparities in trusts in the way that they define, measure and report pressure ulcers. Why is that important? Well, that's because if we don't grade, if we're not all grading the same and if we're not all reporting the same, then we're not able to see what's happening nationally and we're only able to see what's happening locally. We're not able to compare with other trusts. We're not able to compare and see where we stand. And what we need with pressure ulcers, treatment, reporting and care is consistency. So if we can increase our awareness and our accuracy of grading and reporting, then we can help reduce harm. Pressure ulcers are a key quality care indicator. They are nationally recognised. Everybody's talking about them. But the important thing is that we're talking about them equally, properly, that we're all grading the same, that we're all reporting the same. And that is something, we've all got different reporting systems between different trusts. In the acute, there's different reporting systems. The community have different reporting systems. And, Scotland and England have different definitions, terms and systems. So we aren't able to look and say, okay, this is what we're looking at as a whole country, as a whole area. So where does mucosal fit in? Well, mucosal fits in. They've always been around. If you look at the UPAP documents, they've always mentioned mucosal, and what they've said is mucosal pressure ulcers cannot be graded in the same way that other pressure ulcers are. And that's pretty much all that was mentioned. It's never something that's been widely discussed. But with COVID-19, we saw a huge increase in patients in intensive care, and we saw a huge increase in patients who were getting proned. And with that, and with the increase in patient load, with the very, very overworked staff, with PPE, with all the devices and things, we were seeing an increase in mucosal pressure ulcers and device-related pressure ulcers. And with that increase, there's been more attention on these. And what's important is that in where I work, when on our reporting system, mucosal pressure ulcers weren't spoken about differently, they weren't separated. And that meant that when staff were reporting them, they were grading them, they were giving them a grade. And as we know, we can't grade them. But what I'm going to do is I'm going to recap on pressure ulcer grading. You'll all know pressure ulcer grading. I'm sure you can all do it. So it's going to be a whistle-stop tour through pressure ulcer grading, but it's going to bring us to mucosal, and it's going to show you how mucosal fits in with our pressure ulcer grading, and explain why we can't grade the mucosal pressure ulcers in the same way we would grade other pressure ulcers, and why that's important in terms of our data reporting. In Scotland, I chaired the short life working group that looked at our grading tool. This is the national grading tool that we use. And what we've done is we've added mucosal pressure ulcers at the bottom there, you can see, as a category, as a grade of their own, because they cannot be graded. And with that, we're putting out education, and we're raising the profile, and we're talking more about mucosal pressure ulcers so that people understand the difference. And so this tool was put out June last year. So let's go through our grades again, and that, like I said, that'll hopefully help you understand where mucosal fits in. I know you'll probably all seen the apple thing, but it works, so I'm just gonna do it again. Grade 1 pressure ulcer, non-blanching. The redness, when you push it, it doesn't go away. That's our grade 1. The skin is intact, the apple skin is intact. Grade 2, got my peeler, and I'm just peeling the skin of the apple. That's all that's coming off. It's just very superficial skin loss. It's just the top layer of skin, okay? It's very shallow. Our grade 2 pressure ulcer, and here's one a grade 3 pressure ulcer, sorry. Our grade 3 pressure ulcer, and here's one I bit earlier, is full thickness skin loss. There's a big bite out of the apple. There's a big chunk of skin and tissue missing. The key here, though, is that although that's deep, you can't see any bone, muscle, or tendon. You can't see the core of the apple. You can still just see the flesh of the apple. Okay, so it's deeper than when we just peeled the apple. It's deeper than a grade 2, but it's not right into the core. It's not a grade 4. And then, yeah, grade 4. The definition of a grade 4 is that there's full thickness tissue loss with exposed or palpable bone, tendon, or muscle. And that's the same as seeing, if you think about an apple, you're seeing the core, you're seeing the pips, and that's your bone, your muscle, your tendon. Okay, that's what makes it different. So even though there's a big deep hole in this apple, it's still just a grade 3 because you can't see the core, you can't see the bone, the muscle, or the tendon. And then there's our grade 4 with bone, muscle, and tendon. Our ungradable or unstageable isn't called ungradable because you cannot grade it. In terms of, you're not able to grade it. We sometimes in the acute, we've seen, nurses saying ungradable because they don't know the grade, or like mucosal, they're saying it's ungradable because you can't grade it. But an ungradable pressure ulcer, it means that there's something obscuring our ability to see the base of the wound, to know the depth. So we know that we've got more than a grade 1, but with this chocolate in front of the apple, or with slough or necrosis, you're unable to expose the base of the wound. Therefore, you're unable to say whether it's a grade 3 or a grade 4, and you're unable to grade it. Once this has been removed with debridement, then you would be able to grade that. And our deep tissue injury, that is where we've got damage, but the skin is still intact, but there's damage. You can see bruising, it's soft to touch, and the epidermis is intact, but there is an area of discolored skin. Okay, it's either firm, but it's quite boggy. It's warmer compared to the skin around it. To note, obviously, with these are harder to see in patients with darker skin tones. And they can also include a small blister. Mucosal. Mucous membranes are the moist lining of body cavities in organs, for example, the tongue, the mouth, nasal passages, the genitals, and the rectum. Because mucosal tissue doesn't have the same layers that the skin does on the rest of the body, for example, in the penis there, you can see there is no underlying bone, muscle, or tendon. So no matter how bad the damage is on the cheek or on the penis there is no bone, muscle, or tendon that can ever be exposed. So by definition, the grade 4 pressure ulcer is exposed bone, muscle, or tendon. You can't get a grade 4 pressure ulcer in a mucous membrane because the structures are different. So it's not an apple, it's a banana. It's a completely different thing. So if you look at my banana, no matter how badly I damage it, you're never going to see the pips. You're never going to see bone, muscle, or tendon. So you're never going to be able to grade that in the standard way that you would as a 1, a 2, a 3, or a 4. Hopefully that makes sense. Hopefully my bananas explain that to you guys. So that's where mucosals have come in. So the initial problem that we were having was that on our reporting system, your options were, you've got pressure ulcer, hospital acquired, and then people would say it's a device related pressure ulcer caused by a device. Often it's caused by ET tube or catheter. And then the nurses or whoever's reporting was selecting and saying they had to select a grade, and the grade options that we had were just 1, 2, 3, 4, deep tissue or ungradable. And it was therefore going down as an ungradable. But as you can see, that's a different thing. That's an ungradable and that's a mucosal pressure ulcer. They're completely different. So we've added mucosal pressure ulcers into our reporting system for data, for our pressure ulcer and collection data. And I know that that's happening throughout a lot of the trusts now in Scotland, and I'm pretty sure it's happening I know it's happening in places in England, but I've been not working in England, I can't say for sure how universal that is. And with that new addition to the incident reporting system, we felt that it was important that our grading tool that the nurses look at to help with their grading incorporated mucosal pressure ulcers, so that they can understand that they are separate in themselves. They are almost a grade or a category in themselves. And like I say, mucosal has always been around. I had them when I worked in intensive care. They've always been around, but they were few and far between. And with the increase in them, it's important that our data reflects that. So instead of saying we had this many ungradable pressure ulcers, we can say, well, we had this many ungradable and this many mucosal, because they're different. Another issue we had with the rise of this and another, it was device-related pressure ulcers. So a device-related pressure ulcer is a pressure ulcer which results from the use of devices which are designed and applied for diagnostic or therapeutic purposes. Most mucosal pressure ulcers are caused by devices like an ET tube or a catheter or whatever. However, as you know, medical devices, there's the oxygen tubing, there's catheter bag straps, there's many medical devices, and they can go on any part in the body. We had a gentleman who had a collar on for his neck, and he got pressure ulcers here, and you could see the bone. Now, if you can see the bone, it's a grade 4 pressure ulcer. But if you get a pressure ulcer caused by a device like an ET tube in the mouth, and it causes a mucosal pressure ulcer, then it's not a grade 4. It's a mucosal pressure ulcer. And what we've been having is people getting confused between device-related pressure ulcers and mucosal pressure ulcers, and thinking that they're two different things. And they're not necessarily. And I think what's important to look at is what's a cause and what's a category. So a pressure ulcer is caused by pressure. A device-related pressure ulcer is a result of a device which is designed and applied for diagnostic and therapeutic purposes. A category is the description of the level of damage that has been caused. So yes, it's a device-related pressure ulcer, but it's also a mucosal pressure ulcer. Or yes, it's a device-related pressure ulcer, but it's also a grade 3 or a grade 4. And that's really important, because that is, again, how we talk about what caused it. that's how we then can look at our root cause analysis. Is we can analyze, was this harm, could this have prevented, could we have done something differently? So I just got 2 little case studies to just show you some examples of some mucosal pressure ulcers. So here we have a gentleman who got 2 mucosal pressure ulcers caused by the ET tube, which is the breathing tube that's put in when someone's put onto a ventilator in intensive care. And of course, we saw a lot of that with COVID and the hypoxia caused by COVID. He's got the damage here on the inside of his mouth, and he's also got damage there. That was from the ties keeping the tube in place, and that one in there was from the tube. Now you can see that wounds in this kind of location are going to be really difficult to manage, because they're not somewhere where you can put a standard kind of foam dressing or something. So there were a lot of challenges, and also with it being somewhere like your face, it's something that, you know, is quite shocking. If you wake up from being in an induced coma, you've been very unwell, and you've got sort of necrotic areas on your face, it's quite upsetting. But it is one of those things that when you're very unwell, you are more likely to get this damage. And a lot of these devices, especially obviously the ET tube, they're completely essential. So yeah, it's just about thinking about how would you manage a wound like this? How would you manage this damage here? And here we have a mucosal pressure ulcer, which is caused by an indwelling catheter. You can see it's pretty significant damage, but you still can't grade it as a 3 or a 4 or an ungradable, because you'll never see bone, muscle, or tendon there. Again, you're not going to get a standard foam dressing on that. So it's about thinking outside the box in terms of your treatment plan. And about, do you still need that device that's caused the damage? Can that be removed now? Can you take a break? How are you going to deal with pain? How are you going to deal with the ongoing urinary contamination of that wound area and the bioburden that's going to be caused? So what are the wound treatment aims when we are looking at mucosal pressure ulcers? It's the same as any wound treatment aims, really. We're wanting to do our wound bed preparation. We're wanting to remove any devitalized tissue. We're wanting to make sure that we're keeping the bioburden low. We're wanting to remove any slough or devitalized tissue, and we're wanting to reduce the risk of infection and protect the peri-wound skin. We also want to promote a moist wound healing environment, but bear in mind that these are quite moist areas anyway, so it's probably going to be dressings which are going to reduce moisture rather than add it, and looking at managing things like oral secretions and urine, feces and things like that in those areas, and also bearing in mind that you know, especially if there are, you know, pressure ulcers around the face, that there is going to be that need for the additional sort of emotional, psychological type support for these patients. And yeah, what's really important, especially is when they are being discharged to the community, is making sure that there is a very good and thorough handover and care plan given, because these generally, especially obviously the oral ones, generally are developing in the acute. Indwelling catheters and things, these are in the community and they can develop in the community. But there's definitely something that we seem to be sending out more than getting in. And yeah, that's pretty much my whistle-stop tour on grading and mucosal. I hope that it has been interesting, and I hope that it's made sense to you all. Thank you.
Thank you, Catherine, for that really interesting and informative presentation on mucosal pressure damage. And I think that it's highlighted some of the issues that we have with reporting and categorization. So I think that was very interesting. I'm now going to pass over to Lakshmi, and she's going to give her opinion of what's happened during COVID in the community, and then she's going to give some really interesting case studies. Thank you.
Thank you, Kirsty, and thank you, Catherine, for really interesting presentation. My name is Lakshmi, and I am a tissue viability nurse consultant working in the community in England. And I am very lucky to have experience of both acute and community. So I do share the passion that, you know, Catherine has just shown. And as she said, this is not just something happening in the acute, but happening in the community. So I do hope you have taken note on it, because pressure ulcer remain high on our agenda, irrespective of which part of the country or of the world you're working. So this watch party today is to remind you all of how important pressure ulcer prevention is, because it is about reducing harm to our patient after all. So just to kind of tell you a little bit of what we cover today, and I'm sure you know COVID hasn't been really easy on anyone, be it in the acute or community. So I'll be sharing some of the challenges that we have faced in the community, but also we have seen some benefits, and that will follow with some case study on how we've kind of supported clinicians to manage pressure ulcer despite any challenges. So this is about me, and I'm here today, 14 years as a tissue viability, to share with you why it's still important for me as a nurse to educate other healthcare professionals, our workforce, informal carers or trained carers about pressure ulcer prevention. What were the challenges that we saw during COVID, and why do we think they were challenges? First of all, I'm sure you will all agree with me, there was a rapid increase in end-of-life care that was sent in the community because patients were safer to be nursed at home due to the high risk of contracting other illness if admitted. And obviously COVID was really one of the issues that we didn't want these patients to have, but it's also about the preferred choice of the patient, as we know, in line with where you want to be in your end of life care. We have to respect patient wishes. But that's not only it, we also have seen rapidly deteriorating patients. They might have had multiple comorbidities, but they also might be probably healthy, but due to taken ill from one or the other, they have rapidly deteriorated. And these patients, having taken to bed for a prolonged period, they are at risk. And mostly we also have noted is how many of you can vouch that we have seen patients refusing healthcare professional visits because they were scared of contracting COVID. And I'm sure in the community, many of you will agree with us that we knew we were taking the best using our protective equipment to protect our patient, our staff and ourselves, but still as a human being, that fear was there. We also saw patients refusing their normal carers to attend them, to help them with their activities of daily living, personal care, toileting, repositioning, just to minimize that contact with the outside work. But overall, we also saw a decline in referrals being actioned, not just because there was not the medical professional didn't refer in a timely manner, but the people who actually needed the support did not contact the medical professional to refer to appropriate services in a timely manner. So these are overall have led to kind of patient not getting the right treatment and the right support in a timely manner. And these all led to the pressure ulcer prevention challenge, because how do you prevent it if you're not able to access that patient population? So, but overall, as I say, COVID also brought its benefit. As healthcare professional, when a patient say, we don't want you to come in because we're scared that you'll bring the infection to home. What we also said was that's absolutely fine. Part of my job is also to empower you, empower your next of kin, your carers, your informal carers, so they can look after you with our support. And that's where we introduced self-care. And that self-care was introduced to a wider range of people. And as I mentioned, it could be your friends, it could be their relatives, it could be anyone who the patient would accept the direct support. But Also, we noted there were some patients who understood their responsibility, and they were very happy to have regular virtual reviews or sending us photographs of their wound regularly so that we can review, making sure the treatment was still working, or if the treatment needed to be changed, and we would, let them have the appropriate dressing, send them the care plan step by step of how to look after it. But it was really taking accountability of their wounds. And this has been the key highlight of COVID for me, because we knew patients who wished to retain their independence was able to do so. It was literally a sense of pride for the patient, because they were able to redress their wounds and monitor their wounds themselves with the support of healthcare professional. But at the same time, when they saw the improvement, they knew it was, because they were doing the right thing. So for me personally, it was a benefit that COVID brought to us, because we've been able to use new technologies, a better self-care model, which previously we would not have done easily, but because the patient might not want to do it, or the healthcare professional would be hesitant to upskill that informal carers or their relatives to do it, thinking it's a complex wound, we need to keep hold of it. So it's about, trusting your patient as well. So now let's look at some case studies of how a patient who has taken suddenly ill due to COVID and lost all her independence, and how it was challenging to manage because of all the multiple comorbidities. This is my 82-year-old lady. She was, prior to the fall, being able to mobilize and had capacity, lives alone, had minimal support from carers, because she had a very supportive daughter who will help with the weekly shopping, and she wouldn't have carers because, as everyone else, she believed she still could look after herself. But just one episode of fall have led to that lady being admitted with trauma. And as a result, after 2 weeks of being in the acute, she was discharged home with a package of care for 4 times a day. And for somebody who had nothing previously, to accept that package of care was really hard, because for that patient, it's about losing their independence. It's that autonomy that I used to wash myself. Why do I suddenly need somebody to come and wash me 4 times a day or change me 4 times a day? So literally, it was kind of encouraging these patients that, the support is not to take away that independence, but also to support you going back to that independence. But as you can see, my little lady here, she had capacity. She understands her risk of, not having the carers. And she decided to reduce the care package from 4 times a day to literally once a day or twice a day only, after much persuasion by the family. And on discharge, she developed what we call a deep tissue injury, which, as you could see, Catherine mentioned earlier, it was that damage on the skin, although the skin remains intact, but we know it was deeper damage in the inside. So managing the community, which was absolutely fine. But because it was a new episode of care, because she was not known to the community nursing team prior to that fall, she was assessed. She had all the pressure ulcer prevention advice given. She declined to have an alternating air mattress. And she also declined carers to reposition her or check her pressure areas every day, because she believed that was, inappropriate and they were intruding her personal space. She was somebody who was previously independent, so she would decide she would sit out during the day and only goes back to bed at 8 p.m. and being out on the chair for 12 hours when she now has got reduced mobility, needed support to transfer. That contributed to further damage. She did agree for an air cushion, but it had to be on her normal sofa. She would not have any other armchair or any chair that will support with further pressure relief. The daughter reported that she lost weight, But the patient declined a referral to the dietitian, which, as we know, if you're not optimizing your nutritional intake, it's quite difficult to maintain a healthy skin integrity. She didn't report any pain. She did agree with nurses to, compromise with the pressure ulcer prevention as tolerated. She agreed also to use pad because she had some incidences where she could not get to toilet on time. And this is to show you how quickly somebody who has been independent prior to that fall suddenly taken ill and everything start changing, and why the patient feel that, we are taking that autonomy from them. And obviously from a nursing input, what we do in the community for pressure ulcer management, if somebody is making an unwise decision, declining care, or refusing to engage, we usually complete what we call a mental capacity assessment. This is not just to check the patient's capacity, but also to make sure the patient understood all the risk that may contribute to her health. And in case she's not understanding the verbal, we also make sure she was able to retain, process that information, and able to communicate her wish after acknowledging the risk. In my area, we also do what we call a care contract. That care contract, really what it does, it states out all the information that you've told the patient verbally, but in writing, because some patient might not be able to retain the verbal information, but after reading it, they will able to process and understand that better. So that care contract will really use, it's framed based on the skin model. And what it does, it tells the patient about why it's important to be repositioned, about your skin checks regularly, repositioning, managing your incontinence properly, using the appropriate pad and barrier cream, and also ensuring your nutritional and hydration intake was correct. We also involve the daughter in decision making because patient had capacity and was making an unwise decision. This was just to ensure the patient was well supported and that the next of kin could support the mum in better decision making, because obviously explaining of the risk, because having a deep tissue damage on a sacral area, sitting for 10 hours a day, we know what was going to happen. And obviously, despite all the nursing input and everything, we had an SOS call, what we call like the daughter contacted the nursing to say something was bleeding from the mum's sacrum and she was suddenly in agony. The patient at that time stated she hasn't been to bed for 3 days and she's been sitting on that sofa for 3 days, slept on it. The only time she mobilized was when she was helped to the toilet or had her pad changed. At that time, if you remember the classification of pressure ulcer, that sacrum has gone from deep tissue damage to 100% necrosis, which was what we call unstageable. That means you could not see the base or the accurate depth of that damage. So that patient was referred to us as, the process for community. And initial assessment, we reviewed, we started on autolytic debridement. That means gentle process of removing that necrosis while not like causing more pain to the patient, because at that time her pain was already 10/10. So we were not going to use sharp debridement or other form of debridement to cause her more pain. We did a mental capacity assessment again. We did know that she still was making that unwise decision despite showing her the extent of the damage on her sacral area. We also escalated to our safeguarding, because remember, it's a holistic approach to managing the patient. It's not just the nurse's responsibility. We've got to make sure we're managing the patient from a multidisciplinary point of view. And all that the next of kin, who also had power of attorney for health, was fully involved in that decision making, because she was very upset that the mom developed that, but because the mom had capacity, she would not listen to the daughter as well. We got social services involved again to review the package of care, because as you remember, initially she reduced that package of care. her general practitioner, her GP, was fully on board and supported all the approaches that we did, had a conversation with the patient where she finally agreed to have the dietitian referral because she considered that, yes, I am losing weight and I really need more help now because the pain is too much. The GP would reassess her pain management. We also referred her to palliative care for symptom control. One thing we have to remember in the community, very often when you say we'll refer to palliative, people will think, oh my God, it's end of life. It's not just for end of life. Palliative are also very, very supportive to manage symptom control, and they're the best person to approach that because there are different ways of pain management. So that's the reason why we also got not just our therapists and our GP involved, we also got our palliative care team involved. And as you can see, this was the wound when we assessed the patient. And as I mentioned earlier, we used a skin bundle, which is a national recognized care bundle where, the 5 holistic approach for managing pressure ulcers are completed and needs to be done in line with national guidance. So assessment, A for assessment, as you can see, as I mentioned earlier, everything was done in line involving the next of kin and the patient, so there's better understanding and improve the concordance. We also look at equipment, and we also advise the patient of why it's important to use pressure relieving equipment properly and why this will help minimizing pain and reducing further damage in the future. Most of all, we also had to educate the carers in assessing the skin. But remember, the carers does not just have to be the paid carers. It can also be the family members or any informal carers that's promoting or providing support to the patient. It can be the next of kin, it can be a friend. So whoever is supporting the patient should have that education on regular skin check. And also care, as if you think of repositioning, that patient was sitting for 10 hours a day. So really it's about encouraging the patient why it's important to offload the pressure areas. Us as healthy people, if we are sitting out and I sit for the next 20 minutes, none of you move, literally we'll all start to be fidgeting because we can feel the damage, we can feel the pressure. But what about our patient who can feel it but can't move by themselves, or those who can't feel it at all? This is where your assessment needs to come in. Who needs to be repositioned at what frequency? And that's why it's really important to assess that properly on an individual level. Don't forget your incontinence, because we need to ensure patients are using appropriate absorbent pad and not using overlining of pads over pads, or using inappropriate barrier cream where the skin is already vulnerable there and you're just going to make it worse. And for the nutrition and hydration, very important to make sure that it's really supporting and maintaining the skin integrity. G for giving information. As you could see, we've done the mental capacity assessment, we've done the care contract, we've provided all information both verbally and in writing to make sure that there's good understanding of care, the rationale for the care you're promoting for that patient, and why it's really important for that patient to have that pressure ulcer prevention, because she had a multiple comorbidities which increase her risk factors of developing that pressure ulcer. We love pictures, as you know that, and the attached pictures here is after sharp debridement to remove the necrosis after using 2 weeks of dressing to soften that necrosis. And as I say, post-debridement, you could see the bone was visible. It was really high exuding. There was a mixture of both healthy and unhealthy. And the aim was to help with exudate management, but also to reduce the bioburden in the wound bed. And for that, we started on an antimicrobial enzyme alginogel. We ensure all the skin bundle remain in place, and we requested for the nurses to change the dressing 3 times a week because of the exudate level. At that point, the patient agreed to be repositioned during the day as well. We didn't take the sitting out completely. We agreed that she could sit out between 2 carers call, because we've increased the care package to 4 times a day now. So she was sat out in the morning and go back to bed after lunchtime, which worked really well for her because she gets to see her TV, she gets to sit out for her breakfast and her lunch, and she's understood why. And because of the pain, she understood why it was really important to offload that sacral area. And as you can see, as I say, we love pictures. You can see 2 weeks post the treatment, when we started the enzyme alginogel, you can see there was more healthy tissue than unhealthy in the wound bed. And as the wound carries on improving, we were able to actually reduce the dressing as well. So there was further granulation noted. The pain was now well managed. Most of all, eating and drinking was better. The patient was having a supplement protein, which was prescribed by the dietitian. She was better concording with the treatment because she didn't want to go back to that pain. And she was happier in herself. It improves her quality of life. And the daughter was very happy because she saw the improvement. Every time the district nurses will go in to do the dressing, she would be there taking photograph and showing into her mom. And when both next of kin and patient are looking at the improvement, it really empowered them to say, it's working, let's carry on. And as I say, at that time, because the wound was improving, the daughter stepped in, but everybody has got some issues and not everybody can maintain 4 times a day care package. So she stepped down to 2 times daily care package because of the financial situation. But the family was much more involved. The patient wasn't sitting out for long. As her mobility improved with therapy input, which would mean she was able to stand up with a Zimmer frame, and that could be supported by the daughter to transfer her from the chair to the bed after, within the 2 calls. So she was having her call AM and PM for skin care and repositioning and personal care. But in between the day, the patient mobility had improved because of our therapy input as well. So how do we overcome the challenges in the community? As you can see from that case scenarios, it was not just carers, family members, or tissue viability. It was a lot of healthcare professional involved. So in my area of practice, as I always say, we don't just look at the whole in the patient, but we approach the patient holistically. I know mental capacity is sometimes overlooked. Please do remember, it's really key to patient care. We cannot force treatment on somebody, but we can check whether they understand the rationale for the treatment. And if they are making unwise decision, are we as healthcare professionals giving the right information to them? Also, this helps to improve concordance, because by giving information in writing, we are enabling both patient, carers, and relatives to retain the information and understand better why you want to do what. Equipment, remember, not everybody wants to have a profiling bed or hospital bed, as we call it, or an air mattress. Some people may have some emotional attachment to their previous bed or furniture. This needs to be respected. Your rationale needs to be given, but you also need to document properly your assessment. And if the equipment that they wish to keep, to maintain, like this lady wanted to keep her sofa, there was no problem with us, but she also agreed to have the air cushion on top of her sofa, rather than me saying, well, no, I'm just going to give you a recliner that's got an inbuilt pressure relief device on it, and you've got to use it. So we did respect her wishes, and that's why it built up that relationship as well. So remember, and also very often you will see patients don't want an air mattress. Some people will tell you, I feel seasick on it and I feel like I'm floating all day. It's absolutely fine to feel like that. Have a go yourself on it. If you can't stay on it for 24/7 and one of your patients said to you, this is how I feel, unless you've tried it, you won't be able to understand it. But it's also about explaining the benefit and reviewing After the treatment is completed, can we step down the patient to a normal mattress, which they are more comfortable as they're concording more with the treatment? Because this is what engagement is all about. It's about working with them, not working for them. And this is really some about my experiences from a community tissue viability point of view. But as I said, what Kirsty and Catherine has mentioned, pressure also remain very high on all of our agenda. And I'm just hoping this watch party will generate quite a lot of thoughts among yourself, where you'll be able to share what we've been able to share with you to other disciplines, other healthcare professionals, so that you are able to make pressure ulcer your business. Remember, we are heading towards Stop the Pressure Ulcer Week, where it's in the worldwide celebration to make sure that people know that pressure ulcer is everybody's business. Thank you.
Thank you, Lakshmi, for highlighting some of the many challenges that you face when managing patients in the community during COVID, and also your strategies for managing it. I think they were all really interesting. I'm sure many of those scenarios will resonate with all the healthcare professionals that work within the community. I particularly liked that you also highlighted some of the positive facts, because we forget that COVID was such an awful time, but there were some positive things that came out of it, especially around patient empowerment and self-care. So thanks again, Lakshmi. So we're now going to discuss some of the challenges that our three nations have in managing pressure damage. So my first question to all three nations: so do you have specific challenges in communication and documentation between the hospital and acute setting? So I think I'll start off with what happens in Wales. So we've produced a pressure damage passport that's meant to follow the patients on their journey. However, there have been lots of challenges when patients are transferred between wards or discharged home, and the document's often lost. And also not all health boards are using the passport. So if the patient's transferred to a different health board, then the documentation may not go with them. However, COVID has highlighted that we need better IT structure. And in Wales, we're using a digital record for wounds. And so that's going to be across community and acute. And this includes our Once for Wales reporting documentation. So it means that we'll have a little bit of consistency across acute and community across the whole of Wales. However, there is issues because, of course, this doesn't communicate with GPs. And also, if we've got a patient within the nursing home, then obviously it doesn't communicate there. So we do have some issues in that sort of sense. But I think listening to Catherine's talk, we all have that issue with correct grading. Everyone has that. And we do have some inconsistencies with reporting, especially with moisture damage and mucosal pressure damage. So I'm sure that that's something similar that's across all three nations. So I'm now going to pass over to Catherine, and she can comment on what's happening in Scotland and what sort of challenges you have. Over to you, Catherine.
Yeah, it is a challenge. In my health board, and definitely some of the other health boards in Scotland, we've got different systems completely for the hospital and the community. And in fact, we've actually got some of my treatment room nurses, the GP and the doctor's surgeries, they have their own records and notes. So that maybe in the treatment room, you've got certain records and notes, and then the community has a community system, and then the hospital has a hospital system. So you get a patient in from the community into hospital with pressure damage. You're not able to see look at their wound chart, for example. You're not able to look at that. You're not able to find the care plan. You're then needing to phone the district nurses and say, and then obviously they're out on visits and you leave a message and then they phone you back and then you're finished your shift. And there's a real difficulty in getting that information between the health professionals. If you've got family members, and I think sounds like the ones from, Lakshmi's story, they would have probably been on that. And if they'd had the passport like what you've got, they'd have brought that in and you'd have had those things. But, there's people who don't have family, people's family aren't involved or what have you. And often you go into hospital in a rush and you don't have the time to think, I'll bring that booklet or whatever. So yeah, we really have issues. And then on discharge, the nurses in the hospital, they keep all of their records. We've got computerized wound charts. It's all in the computer system. And so in order to get the care plan into the community, you actually have to ask them to do an extra piece of work when they're really, really busy as it is, and write out a paper form to then put out with the patient so that the traditional nurses actually get it. Or again, to make some kind of phone call handover, which with timings is just a really difficult thing to do. So we really do need to improve that. It's something that needs to be focused and prioritized, definitely. And then again, like I said, with our grading and just an understanding of, if you grade something incorrectly as say a 3, and actually when they get back into the community nurse is saying, well, this is a 4, you don't know, did it get worse? Or did you just have it not graded correctly in the first place? And these things, they really matter. And it's an ongoing challenge that we've got. For really bad ones, the tissue viability team will get involved and will be that link, and I'm very in the lucky position that I do cover both. So I'm able to be that link person, but there's a lot of times when you're not able to be. And with the smaller wounds, we're not involved in every wound. So how do you do it? And I suppose that's we've not yet got a solution, have we?
Yeah, I think that's the same. So Lakshmi, do you have similar challenges in England?
Absolutely. And I have to echo both yourself and Catherine's challenges are the same thing we face. And if anything, as Catherine was saying, communication between acute and the community, very often the message gets in, but by the time the nurses are back to give you that message, the ward are not available to receive, or that staff who requested for it have now gone off shift. So our community nursing where I work have now gone paperless, which means all our wound cares, our documentation are all on electronic patient record. There's no paper document that the family member can take in with them to the hospital to show this is what the nurses have been doing. So, and equally, and this is similar to most community setting across England, our services don't have the same electronic patient record. Our nursing home is still on paper. We are completely on electronic. Our GP has got completely different electronic system, and the neighboring acute trusts work completely on a different system to us. So not all 4 systems will communicate with each other. So if you do want to know what has been done for that patient, there is that breakdown in community. And very often, and I will echo exactly what Catherine has said, it's miscommunication about the classification of the pressure ulcers, which we might know that actually, yes, it was an unstageable in the community, but by the time it's gone to hospital, it might have, debrided and now exposed the accuracy, which is a 4, but it's that difference. So, you can't, and these things, it generate a load of unnecessary paperwork where, if all 4 nations work together, hopefully one day this will be fixed.
Yeah, we should all be on the same hymn sheet with it, really. If we all could see each other's records like you can with, like the DVLA, you can anywhere, or the NMC, anyone can log in and see one system and everyone can get that information. But yeah, we're not there, are we?
No, and definitely, I think we can all see the benefits of a one system that speaks to everybody, because we know that is one of the frustrations. I think another thing that I'm sure that you're all seeing at the moment is patients with long waits in ambulances to get into A&E, and that early skin inspection when they go from one environment to another environment is really important, because otherwise we don't know if patients are developing harm. We don't know when they developed it. And, should we be thinking about these ambulance patients when we look at preventative strategies?
Definitely. And like say, it's the early inspection. I've come across patients with horrendous wounds, maybe 2 or 3 days into their admission, and nobody can tell me
when it started.
Did they come in like that?
Yeah.
When they came in, what was it? And you're really having to play detective a lot. I don't know about you guys, but I think as a tissue viability nurse, you're also a detective. And
definitely.
It's difficult, isn't it? But yeah, I think the ambulance is definitely somewhere where we could be picking up on these people.
But equally, I will add to that, because if a patient is so acutely unwell that they need a hospital admission from the community, we have to acknowledge that they are unwell. So the skin is the most vulnerable at that point. So if they have already got a pressure ulcer, say category 3 pressure ulcer, but they are unwell for something else that they need it, and they're waiting for 8 hours for an ambulance to get to the acute, that cat 3 can deteriorate in a matter of just that waiting time.
Definitely.
And the district nurse may have seen the patient that same morning and call an ambulance for the patient. Families waiting for her, and they saw a cat 3, but by the time it gets to Catherine there, the category 3 might have deteriorated further. And this is where having that communication is really important, because then, you know, as TVN, as trust, we can communicate to say, this is what I saw. You log into my system, you can see what the wound was like this morning. But unfortunately, by the time she's come to you, it's deteriorated rapidly.
Yes, you almost need a RAG system, a red, amber, green, so that, you know, when they have their assessment before they go in, people are highlighting that these patients are high risk and need urgent pressure relief, really.
Yeah.
Really interesting discussions. I think we'll move on to the next one for our nations now. So many of our complex patients with complex needs and comorbidities are managed by care packages delivered by care assistants. These care assistants are in a key position to spot early pressure damage and also raise concerns early. So we can put early preventative strategies in place. So do you think there's enough emphasis on training and education on pressure ulcer prevention for carers working for local authority or care agencies? So here in Wales, you know, the education for non-qualified carers does vary, and I'm sure that you're all going to say the same thing. So Social Care Wales has introduced a standardised qualification for new carers called the All Wales Induction Forum. And Social Care Wales also state there should have, you know, any carer should have this NVQ or QCF or City and Guilds qualification. There's a small element in these qualifications on pressure damage, but it's not massive. Within my role at the moment, part of my role is at teaching and education. So we have been commissioned by some local health authority or local authorities that recognise that educating carers in pressure ulcer prevention is really important. So we are so excited about that. But again, it's not across the board, and it's very hit and miss what education they get. So, you know, we also know that when we're learning from a pressure ulcer incident, are we actually passing this on to the social carers as well? Because of course, they may be involved in the care somewhere across the line as well. So how does this vary? First of all, I'm going to pass firstly to Laxmi in England. What do you feel about it?
So I completely agree with this point, Kirsty. And one thing we have to remember, the carers who are employed by social services to deliver care in the patient home are very often, you know, not qualified carers, like I would say an NVQ sometime. They've got basic knowledge. And these care agencies, some of them are private, so they will invest in their staff having good moving and handling first as mandatory, but topics like pressure ulcer prevention are their least concern. So the most important, they'll train their carers to be able to use a hoist, a sliding sheet to move the patient safely, but there's no such thing as educating them on pressure ulcer prevention. So I'm going to speak on my local area only, but I know it doesn't happen across many other settings. So in my area, we actually identify a very high significant pressure ulcer, which were developed in the community. And these patients were not known to any of our community settings like healthcare professional within our trust. So we took that back to the quality assurance team, and we actually did as like an audit kind of an QI perspective, quality improvement perspective, we introduced a pressure ulcer prevention training for all home care agency over 6 months. And we did it via Zoom, so they could reach it out from wherever you want. So having the backup of the local authority on that and the quality assurance team, which is a part of the commissioning group, the CCG, as we call them, it was really important because they mandated these care homes for all the carers to have that training. And we saw an improvement in skincare when these carers, after having the training, were picking up the phone and calling the GP to say, Mrs. So-and-so has got redness, we need barrier cream. Whereas prior to this 6-month education, there was nothing. And we will only get a referral from the GP when Mrs. So-and-so has already developed a pressure ulcer. But as I say, it's only happening in my local area. It's not something that we could sustain because, you know, resources with increase in clinical activities, there's not something we can maintain long term. But I think if we look at it from a quality improvement point of view, if the local authority can invest in there or get the home care agency to make it part of their mandatory, just having like an hour of pressure ulcer prevention as part of these staff induction, it will make a difference in patient care.
That's really interesting, Lakshmi, because it's definitely a missed opportunity. And I think in Wales, they're trying to integrate health and social care, so that will definitely improve things. So Catherine, how are things in Scotland? What challenges do you have with social care?
Being more on the acute side, this is something which I'm not going to say I'm an expert on, especially not for the whole of Scotland, definitely not. In terms of locally, we haven't been involved specifically in doing any training with home carers. Most of them are private care agencies who are kind of taken on board or like paid through the council or what have you, but they're mostly, you know, they're a lot of private care agencies. What we have done though, which came through with COVID, was we were given and all trusts were given funding from the government for care homes, and obviously looking at reduced pressure ulcers and, you know, care of patients in care homes. And the funding was used for a care home team. So we've got a team of tissue viability nurses specifically for the care homes that we have. We've got over 100 care homes in our local trust, and they're hugely care, you know, mostly carers, a lot of carers in there, and they have just been getting specific training made from the care home team. They've been going out to the care homes, giving the training. We've got a lot of virtual training and a lot of support, and we're seeing huge improvements. And there was a real need for it. And it's been quite an exciting time for us. It's the first sort of just about a year now that we've had the care home team in place, and we've really been working with the carers in that sense. But yeah, in terms of the home carers, we haven't unfortunately been massively involved, and it sounds like what Lakshmi's doing is brilliant, and hopefully it's something that more places can be doing.
Yes, and I think that integration and working together between health and social is a very important part of that.
Absolutely.
So finally, going to move on to our last question for the three nations. So what are the specific issues regarding to discharge of a patient with pressure damage or somebody who's at risk of pressure damage from hospital to community, or vice versa? So for me, it goes back to what Catherine mentioned earlier about the categorization, the reporting, and the identifying correctly that it's pressure damage, not moisture or something else. Another challenge that we have is the difference in equipment that's provided and who will provide it. So across Wales, it varies hugely. In my previous role in the health board, we had the same provider for beds and mattresses, whether you were hospital or community. So that did help a lot with continuity of care, making sure that the patients had the same equipment wherever they were going. However, we did have issues if patients went to a different health board or even to a nursing home. So we can't guarantee the efficacy of the equipment they use there. And also who would supply the equipment. We have that problem as well sometimes. And we also have problems in community, especially with patients or relatives thinking they're being very helpful and purchasing equipment. And sometimes it's suboptimal. And in some cases, it's led to the development of pressure damage. So, these are specific problems that we have. But I think the main thing is about that reporting and that communication between hospital and community, definitely. So we're going to throw it back to Catherine. What sort of issues do you have or within your own area of work?
Yeah, very similar, unfortunately. We I mean, we've had patients with significant pressure damage. In fact, we had a gentleman who his air mattress deflated at home, and he lay for a couple of days on a flat mattress, had really significant, terrible pressure ulcers all down his right hand side, and he was then, once we got him sort of medically well, he was then delayed discharge because we were unable to get a high enough spec of mattress for him in place for his discharge, because you've got to, it's different providers, it's different ways to go through, there's different availability, and yeah, that's a real challenge, and there is delayed discharges, and you can get that pressure. Okay, we need beds, we're very, very busy, we can't really be holding on to patients for equipment, but on the other hand, you have to really fight and say, well, we can't send them out without equipment. So yeah, that's an issue, definitely, sourcing equipment, and equipment just being the same. You know, if somebody's getting discharged and they don't have specialist advice, for example, you know, a ward patient, and the nurse on the ward saying, oh, well, they're on X cushion. If they don't know what's like for like, they don't know, okay, well, this is the same standard, this can do the same level of pressure, you know, category of pressure ulcer as this. And that's also really hard. That, I mean, there's gazillions of different names and brands, and everyone's making a cushion and everyone's making a mattress, and how do you know what's like for like when you don't have that? So that is a challenge. And yeah, like I said, the grading, making sure that's accurate, making sure it's handed over, making sure that actually someone's getting discharged with a new wound, that they are actually know that they're going to get picked up by the community, or who's going to pick them up. Other issues that we had were, in terms of patients, they got a lot stricter, understandably, about patients trying to really encourage people to go to the treatment rooms. And where, you know, a lot of people thinking, oh, well, they've got pressure ulcer, they've got to the district nurses, and actually it's about re-educating, saying actually that patient is mobile, they could get to the treatment room, and giving them that guidance towards discharge to the treatment room, because otherwise, again, you're getting more delayed care. Yeah. So yeah, I'd say that's an issue. And an issue that we have in hospital and community, which is one of my bugbears, is people on these beautiful high spec dynamic mattresses, and then sitting all day on a rock hard chair with no cushion. And that's just, you think, if you need a mattress, then you need a cushion. And if you don't need the mattress, you know, then let's step down. And that's again what Luxmi said. We don't step down quite as quick as we step up, and we don't match our mattresses to our cushions, or the other way around, and that drives me mad.
Yeah, I think that's a problem we have as well, and that people are a bit frightened, they're risk averse to step down, especially if the patient's going out to the community. They feel they've got to be on this very high specification mattress.
Yeah.
So Luxmi, what sort of problems do you have?
I think both of you have said most of my challenges, but from a community perspective, I would also add what we see in the community, and you might not see that a lot in the acute, but patients switching off the air equipment because of cost of energy.
Oh yes.
So yes, we do have issues with, you know, having not the same mattresses, and they will come out in the community, say, I want the same equipment I had in the acute, but because we're a different contract, we can't provide that. And as a result, you know, there's always that, you know, issues and discontentment. Why can't you give me that equipment? This is all same for us across England, where I work in my local area, but we have seen a lot of people, and I think sometimes we are guilty of what we do as well, because we're going to say to Mrs. So-and-so, we're going to see you 3 times a week, say Monday, Wednesday, Friday. So they know the district nurse will come at certain time and certain day, and the equipment remains switched off when they know the nurses won't be in.
Oh,
and we have been picking that up, because why is the wound deteriorating when everything should be in place? And then it just turn up when, you know, you randomly change visit because of staffing, which we know we have seen during COVID, especially where we had to move diaries around to do visit different days. And that's where these issues has been flagged. So how can we, when we're providing equipment to the patient, to the relatives, and don't forget, most of them are elderly, And if they're, as you saw in my case today, if they're reducing package of care from 4 times a day to twice a day due to financial, reasons, how can we educate them to let them know that actually the equipment we are giving to you is not going to use all of your electricity bill for that month? It's about, really making sure that companies are supporting us with the appropriate information, so our nurses at ground level can give that information to the patient, to the relatives, so they understand that it's not going to impact on them financially. But also, I completely agree with this step down, because we feel, oh my God, we've got a pin to protect. So the patient has healed, and okay, yeah, she has a healed cat-free pressure ulcer, and she's now walking around the house everywhere, but we're leaving that air mattress in when she's sitting out a whole day to watch TV. Is it not easier or better to give her an air cushion for prevention, knowing that she can now self-reposition and she's not even using the bed daytime? So it's about empowering our staff to make that decision confidently. And as you say, it's different contracts across different health board. So it's one equipment doesn't fit all this, the areas, the settings, care homes, residential home. Who gives air equipment to them? I know for us, the residential home, the district nurses support them with ordering equipment when they develop, we have got an equipment decision tree making, but in the nursing home, they have to purchase their own. How do you know they meet the spec? How do you know they are at that high level that it needs to be? And I think on my final point on this one will be patient buying online. I'm not going to mention any online platform here, but yes, we do see that all the time. And then they're getting all sorts of cushions, all sorts of equipment, devices, and sometimes some donuts ring. And when you go in there, the first day there's nothing. The next time you visit, there's a nice ring of purple discoloration around there, which already caused deep tissue damage. So it's about educating as well. So hopefully, with this watch party, we can make a bit more public awareness.
Thank you, Lakshmi. I think it's been a really interesting discussion. And I think we found out that across the 3 nations, that our problems are very, very similar. So I would like to thank you all for listening to our watch party, and thank you to Lakshmi and Catherine for their insightful presentations, and also to Flen for sponsoring this watch party. Next week, on November the 17th, is World Stop Pressure Day. We hope that you've taken away some aspects for your own practice, and this is important so we can work together to stop patients developing pressure damage and prevent patient harm. Thank you all for listening.
So if you've enjoyed watching the presentations today, you can download and watch again via the Flen website or on YouTube. Thank you for listening.